I'll come to the pathology so that you will get more clarity on myasthenia gravis. So I will start with my next topic, that is myasthenia gravis. So as I've already told you that, so what happens in myasthenia gravis, right? So see here, in myasthenia gravis, please write down along with me, right? If you are making notes, try to make notes along with me. Otherwise, I will upload the notes after the class, right? So antibodies are produced against the nicotinic acetylcholine, ACH is acetylcholine receptors. Please don't get confused in tomorrow's NORCET exam. If they ask you what is myasthenia gravis, you people will tend to answer it as acetylcholine. So here the antibodies is not getting produced against the neurotransmitters. Please don't get confused. Here the antibodies are getting produced against the receptors, where this acetylcholine will go on bind to that receptors. Against this receptors, antibodies are getting produced, right? So that is what is the main pathology in myasthenia gravis. Okay, right. So again, I'm telling you, the antibodies are produced against the nicotinic ACH receptors. That's the main pathology seen in case of myasthenia gravis. Now let us see. See, as I've already told you in my microbiology classes, right? Myasthenia gravis, when I'm dealing the hypersensitivity reactions, I told you type 2 hypersensitivity reaction ka example is your myasthenia gravis, right? So myasthenia gravis is a type of type 2 hypersensitivity reaction, right? See this myasthenia gravis, unlike your Guillain-Barré syndrome. What happens in Guillain-Barré syndrome? Yesterday I told you in Guillain-Barré syndrome. So that is the there which system is getting affected? Your peripheral nervous system. That is your motor nerves are getting affected, right? But and along with that, you will also have autonomic nervous system involvement, right? So due to which the cardiac arrhythmias, orthostatic hypotension, many things are going to happen in Guillain-Barré syndrome, right? But it will not happen in myasthenia gravis. Okay, myasthenia gravis, here yes, antibodies are getting produced, right? But here only your skeletal muscles will get affected. There is nothing, no involvement of your autonomic nervous system, no involvement of your central nervous system, nothing like that. Okay, only the skeletal muscles. So there are a few types of muscles. I don't want to talk on anatomy right here, right? You have skeletal muscle, smooth muscle, right? So only the skeletal muscles are affected in myasthenia gravis, right? So whatever the muscles which are attached to your bones, the skeletal muscles are affected in myasthenia gravis. Let me tell you how these patients are going to come to the OPD, right? So what happens in myasthenia gravis? It affects only the skeletal muscles. Please don't get confused. It affects only the skeletal muscles, right? And most commonly involved. See, myasthenia gravis. So which muscles do we use very frequently? Don't tell me hands and legs. Of course we use our hands and legs very often, but yes, which muscles do we use more frequently? Eyelids. Even within a second I'm blinking number of times, right? So whichever the muscle you are using, whichever the muscle you are using very oftenly, that muscle gets affected first. The first muscle to get affected is that, right? The most common muscle which is involved is your extraocular muscles, right? And now my next question will be, what are all the extraocular muscles? Can you people tell me what are all the extraocular muscles? Suppose if I want to move my the eyelid upwards, which muscle is going to help? Tell me. So suppose I'm closing my eyes and I'm opening my eyes. So which muscle helps in uplifting the eyelid? Tell me. So suppose if you're getting the same question in tomorrow's exam, so what are you going to answer? So which muscles are going to get affected is extraocular muscles, right? So leading to drooping of eyelid. So drooping of eyelid, what do we call medically? Ptosis, right? So there will be drooping in the eyelid. So your eyelid cannot, the patient cannot open the eyelid properly and it will droop, right? So that is called as ptosis. So somebody is telling, Vijay Lakshmi is telling superior rectus. Any other muscle that helps in my uplifting the eyelid? So I need the correct answer. So let me see who is going to give me the answer. Any other people who can give me the right answer? Which muscle helps in uplifting the eyelid? I've already told you in my RRB capsule course, I think so. Yes, tell me. It is levator palpebrae superioris. No, why are you giving me the optic nerve, my dear Viru? I'm not asking you the nerve. I'm not asking you the nerve. Although you have given the wrong answer, your levator palpebrae superioris is not supplied by optic nerve. Okay? Uh, Optic nerve is not the right answer. The one that helps in uplifting the eyelid is a muscle called levator palpebrae superioris. Okay, so which French are you talking about, Hemlata? I did not get you. Leave it. Okay, so anyways, so keep it aside and let us continue the topic, right? So now, if you take neuromuscular junction, right? So consider this as neuromuscular junction. And now what happens in neuromuscular junction? There will be one neuron and there will be one more neuron here, and the neuron which is sitting uh, upwards, that will send the, how it is going to send the impulses. The chemical impulses is by neurotransmitters. The main neurotransmitter which is present in your skeletal system is acetylcholine, ACH, right? So now the presynaptic knobs, this one, if you consider this is presynapse, this is the post synapse, and this junction is called as synapse, right? So from the presynaptic neuron, there is a neurotransmitter called acetylcholine which gets released. So this is, I'm talking about the normal physiology. I'm not talking about myasthenia gravis. Please don't get confused. So what happens normally in our body? Suppose if I want to contract this muscle, right? Now what is happening there is, so there is one neuron which is called as presynaptic neuron, and there is one more neuron which is called as postsynaptic neuron, right? So this is presynaptic neuron, this is postsynaptic neuron, and the space in between is called as synapse. Okay, right. So here the myasthenia gravis which we are talking about, that is postsynaptic defect. Very important question. So tomorrow if they ask you which type of defect is your myasthenia gravis, don't scratch your head at the time. So I've already told you it is postsynaptic defect, right? So what is happening here, the neuron is, whatever it may be, there are many, then there will be connection, there will be chain of neurons, right? So I'm taking only two neurons among that, right? So there will be one neuron, and just below that, so there will be the presynaptic neuron and presynapse and postsynapse, right? And there will be synapse. So now the presynaptic knobs of the neuron is going to secrete a neurotransmitter which is called as acetylcholine. And now this acetylcholine, here you can see these blue color receptors. These are called as acetylcholine receptors. And now this acetylcholine has to go and bind to these receptors. Okay, this acetylcholine molecules has to bind on these receptors, and now the muscle can contract. Okay, this is the normal muscle contraction. This is how the normal muscle contraction takes place in our body. So what is happening in myasthenia gravis? What did I say in myasthenia gravis? So here the antibodies are produced against the acetylcholine receptors. So see here, these are the antibodies which are produced in our body, right? They are going and binding to the acetylcholine receptors. Common sense. So suppose if in your chair, so suppose in this chair only one person can sit. Suppose instead of me the other person came and he was sitting here. So where should I sit? There is no place for me to sit, right? So similarly, what happens to the acetylcholine receptors? See, acetylcholine receptors are blocked now by the antibodies. Now the acetylcholine cannot come and sit there and it cannot act. So no muscle contraction. There is no muscle contraction. It leads to muscle weakness, right? So this is what is happening in myasthenia gravis, right? So there are few drugs that can exacerbate the condition. This can be asked. It's a very important question for your NORCET exam. What if in tomorrow's exam, if they're asking you which drugs can exacerbate, in the sense which drugs can aggravate the condition of myasthenia gravis? Instead, I can also say this as, so these drugs are contraindicated in myasthenia gravis. So what are those drugs which are contraindicated in myasthenia gravis? So mainly aminoglycosides, very important, like your streptomycin, right? Gentamicin. So all mycins or aminoglycosides, right? So they can exacerbate muscle weakness in case of myasthenia gravis. So these drugs are contraindicated in myasthenia gravis. Now, let us see how the patient comes to the OPD, right? I've already told you the main complaint the patient will take and come to you is, so they'll come to you with ptosis. So they will tell you that, so there is drooping of the eyelids, right? So there is weakness of the eyelids and he cannot open the eyelids properly. So this is the main complaint. This is the most common complaint that you're going to receive in myasthenia gravis, right? So the first sign of myasthenia gravis will be the ptosis, right? And so now what I'm going to do is, so immediately now there is a patient in front of sitting in front of me who is giving me the complaint of ptosis. Now I should confirm that whether it is related to myasthenia gravis or something, it is related to any other condition. So there are another conditions like Horner syndrome and different things which I'll be teaching you in the next forthcoming sessions, right? So where there will be ptosis in that conditions also. So now how I will differentiate this as ptosis which is associated to myasthenia gravis or any other medical condition? Now what I'm going to do, I'm going to take my finger and I'm going to lift the eyelid. So if I lift one eyelid, so suppose if I lift the left side eyelid, so automatically the opposite eyelid will fall down. So this is, it will fall like a curtain. So that is called as curtain sign. Okay, so here the clinician, he's see here, he's uplifting the eyelid here. So he's pulling the eyelid, he's trying to open the eyelid, and what automatically what is happening to the opposite eyelid, so it is falling down. So it will fall like a curtain. So that's why this is called as curtain sign, right? Where are you going to see curtain sign? In case of myasthenia gravis. Okay, and if you ask me, ptosis is what type of ptosis you're going to see is, it is asymmetrical ptosis. So one eyelid will be open and one eyelid will be closed, so there will be asymmetry. So right, so there will not be symmetrical ptosis most of the times in case of myasthenia gravis, right? And there is something called diurnal variation. What is this? See, I've already told you. So whatever the muscle which we are using very oftenly, that muscle will undergo weakness, right? So here the client will what is the history the client is going to give you is, sir, yesterday night it was fine, and I was just sleeping, and I woke up from my bed, and then I went for my office and started working, and all of it, right? As the day progresses, my weakness increased. Right after taking rest, my weakness improved. There is relief. The symptoms got relieved. So this is the case. This is the scenario you are going to listen. Suppose if the same question, if they're asking you in NORCET exam tomorrow, just mark an option called myasthenia gravis. So again, I'm telling you here, what happens is every client of myasthenia gravis is going to give the same complaint. So he will come and say that, sir, when I'm going to office, I'm fine. When I'm coming from the office, I cannot come, and I'm feeling there is a lot of muscle weakness, and my eyelids are drooping out, and many things are happening. So this is the same, this is the complaint that you are going, he's going to utter in front of you, right? So this is a classical finding, this classical symptom you are going to see in case of myasthenia gravis, right? So what did I say now? See, by taking rest, the symptoms get relieved. Okay. So as the patient if the patient is taking rest, if he's going to bed and he's taking rest, and if he's not using the muscles, he will be fine. There will be no weakness. And once if he starts working in office, right, he will be continuously working 6 to 8 hours. So as by the evening, he will complain, he will come to your OPD with weakness, right? So this is diurnal variation. So in the night there will be no weakness, in the morning in the daytime there will be weakness. As the day progresses and the day gets completed, there will be weakness, and by taking rest it will get relieved. So this is called as diurnal variation, which is seen in case of your myasthenia gravis. Okay, right. And sir, you are telling us muscle weakness, muscle weakness, muscle weakness. Tell us which muscle is, tell us a little more about muscle weakness. So, muscle weakness mainly, as I said, that skeletal muscle weakness. So, mainly your pharyngeal muscles also can become weak in the myasthenia gravis. So, whenever your pharyngeal muscles become weak, he cannot swallow, right? So, difficulty swallowing is called as when pharyngeal muscles are involved, right? So it can lead to difficulty in swallowing, and difficulty in swallowing, what do we call medically? Dysphagia, right? So dysphagia can be seen. And coming to the limbs, your legs and hands, now as I've already told you, there will be weakness. So it's always asymmetrical weakness. One hand will be fine, the another hand will be weak, right? So there will be asymmetrical weakness, proximal and asymmetrical weakness you're going to see in case of myasthenia gravis. And please note, here the patient will tell you that he's having weakness, and what immediately clinician is going to do, a neurologist is going to do, he will take immediately knee hammer and he will check for the reflexes. So in myasthenia gravis, the sensation will be bilkul normal, and the reflexes also will be bilkul normal. This is one important finding that you are going to see in case of myasthenia gravis. And there will be voice. If you can able to see the voice of myasthenia gravis, since there will be weakness of the pharyngeal muscles, so and facial muscles, so there will be hot potato voice. Excellent, Manikanta. It is hot potato voice. Hot potato voice, which you are going to encounter in the cases of MG, right? And there is a small bedside test that you can perform. Simply what here the clinicians are going to do is, they will go bring ice from the fridge and they will place the ice pack on the eyelid. See here. So here there is ptosis of the left side of the eye, right? So now once you place the ice pack for 2 minutes, and you will wait for 10 to 15 minutes, and there will be improving in the ptosis. So now there is, you can see the palpebral fissure, there is increase in the space. So that means he can able to open the eyelid properly, right? So this is called as ice pack test, which is a bedside test which is performed in case of myasthenia gravis. So what is ice pack test? So just go get some ice from the fridge and you will place on the eyelid, so where there is ptosis, and after 2 minutes, you will wait for 10 to 15 minutes, you will place it for 2 minutes, and then after 20 to 15 minutes there will be improving in the ptosis, right? So that is called as ice pack test. And there is one more test which is done and very frequently asked in the exams, very important to remember, which is called as edrophonium test, which is called as edrophonium test, which is also called as tensilon test. Very important. So very frequently asked question. If you can able to see the previous year question papers, it's very frequently asked, but I don't know why the people are asking. It is outdated and it is no more performed nowadays. It is outdated. I think in 2018 and 2019 the guidelines have banned performing this procedure called edrophonium test. Why it is banned? In the sense, see, Edrophonium is a drug which can decrease the heart rate, right? It will decrease the heart rate. That means it can cause cardiac arrest at any time. So whenever you're giving edrophonium to the patient, always in the opposite hand, you need to have atropine in your hand, right? So you should have atropine in your hand, right? So it's banned, it's outdated. I've already mentioned it here. Your edrophonium test is no more performed. That is repeatedly asked question in your NORCET exam, right? Coming to the most specific workup. Now, how can you people tell me what is the most specific investigation that I can do in case of myasthenia gravis? Tell me the most specific investigation which is done in case of myasthenia gravis. Let me see who is going to give me the right answer. So, as soon as if any patient gets, if I want to diagnose any client with myasthenia gravis, which test I'm going to perform? This edrophonium test, I've already told you, it's an outdated test. ICE-PAC test, it's a bedside test. It's different, right? Muscle conductivity test, okay? No, my dear, I told you what is the main pathology, common sense. Antibodies are produced. So that antibodies I can test, right? So that is the most specific workup that I'm going to do. I will check for the acetylcholine receptor antibodies. Okay, I'm writing it in short form. Please, you can elaborate it. Okay, so acetylcholine receptor antibody test I can do. This is a very specific test. If these are coming positive, you can very well diagnose it. It's a case of MG, right? There is one more type of receptors that you need to remember, which are called as anti-MuSK receptor antibodies. Anti-MuSK antibodies. So these are Khatarnak antibodies, right? So if you are finding anti-MuSK antibodies in any case of myasthenia gravis, that means he's going to develop respiratory failure, right? Very severe form of antibodies, right? If you are finding this in an anti-MuSK antibodies, right? So the patient will develop respiratory failure. And usually how do we treat myasthenia gravis is by giving steroids, right? I can give steroids like prednisolone, or I can give pyridostigmine, but this is when your acetylcholine receptor antibodies are coming positive. But if your as anti-MuSK antibodies are coming positive, it will not respond to prednisolone, it will not respond to pyridostigmine. I have to give a special drug which is called as rituximab. Rituximab. And now my next question for you people will be, in pediatrics, somewhere I told you about rituximab. Can you tell me in hematology, somewhere in pediatric hematology, I told you there's a one condition where I'm going to give rituximab. Although there are different conditions where I'm going to give rituximab, but yes, I think in my previous lectures, I would have given you the condition, right? So there is something called in pediatric hematology when I'm discussing tomorrow in pediatric hematology, there is a condition called ITP. Idiopathic thrombocytopenic purpura. It's a platelet disorder where you are going to treat it with rituximab. Okay, ITP. Okay, idiopathic thrombocytopenic purpura. Very important condition. Very oftenly, if you go to pediatric ward, hematology ward, you can find many patients of ITPs. Many patients of ITPs. Like how your thalassemia and hemophilia is familiar, ITP is also very familiar in hematology wards. And these are the children who will frequently fall from the bed and they develop hematoma, right? So they will fall from the bed. This is what is very commonly happens in hematology wards. Okay, right. So now coming to the next, what they're asking you here is, see, this condition in most of the cases it is associated with, very importantly, see, I think no one of you got doubt. So from where these antibodies are getting formed and why these antibodies are formed? In most of the cases, if you can see, whenever a patient comes to my neuro OPD or medicine OPD, and when he sits in front of any doctor, and if we want to make a diagnosis of myasthenia gravis, immediately the doctor is going to write an investigation. So he will write CT chest and he will send the patient to have the CT chest and come. Why CT chest? So this is an autoimmune disorder. Why should I perform CT chest? Any answers? Why should I do CT scan in myasthenia gravis? Those have already, I think every one of you have completed BSc, right? So you would have studied in medical and surgical nursing. Tell me, no, Indumati, please don't give me this kind of, no, not don't give me LRTI, whatever it may be. No. Why should I check for infection? Why I'm bothered about infection here in case of myasthenia gravis? I'm not bothered about my infection here. Something which I'm bothered about is anterior mediastinal mass. What is that? I've already told you the answer. 50% of answer I told you. Let me see who's going to give me the answer. I am going to send you a gift if anybody answers me this. Tell me. Why CT scan in myasthenia gravis? I can do acetylcholine receptor. I can take a blood test. I can check for antibodies. I can diagnose with myasthenia gravis and I can start with prednisolone. Right? Why should I do a CT scan? So let me see who's going to be the answer. Yes? Okay, so let me tell you, I think you people will not answer. Okay. Excellent, Manjula. Yes, Manjula had given me the right answer. I'm going to check for thymus gland. Okay, in most of the cases, no. Hemalata, it is not the, no. Myasthenia crisis will affect respiratory system. No. How I can see, I'll come to that. Okay. What you are thinking is something, the complication which you are thinking, that is not related to CT scan. So CT scan, why neurologist is going to advise in a case of myasthenia gravis is thymic hyperplasia. There is something called thymic hyperplasia. I'm going to rule out. In most of the cases, due to which this thymic hyperplasia, these antibodies are produced in the body and these are causing the damage to these are blocking the your ACH receptors, right? In 85% of cases, I'm going to see thymic hyperplasia. In only few cases, I can also see one more condition which is called as thymoma, right? So thymic hyperplasia or thymoma, right? So these are in most of the cases of myasthenia gravis. So there will be anterior mediastinal mass, there will be a thymus gland ka hyperplasia or thymoma, right? Right, now tell me how I'm going to manage the case of myasthenia gravis. The first line management will be always in Guillain-Barré syndrome. What did I say? The antibodies are produced now. The antibodies are present in the body. It is in your blood, right? Now what I can do is I can neutralize the antibodies by giving some drugs, or I can remove the antibodies from the body. There are two options. So similarly here also there is antibodies, right? Now what I can do is I can neutralize the antibodies by giving immunoglobulins, IVIG, right? So if not, I can also do plex. What is plex? Plasma exchange. I can remove all the antibodies which are produced by your thymus gland, and I can now the patient will get relieved. So this will be the first line. So suppose and in every MCQ discussion, I told you myasthenia gravis means immediately what should come into your mind is 3 P's should come. 3 P's. So 1 P for prednisolone, one more P for pyridostigmine, and the last P stands for plasmapheresis. That is your plex. Plasmapheresis. Right? Plasmapheresis. Plex and plasmapheresis is one and the same. So you're going to remove the antibodies. You remove where these antibodies will be present in the plasma. So all the plasma will be removed and they'll infuse the plasma. So that is called as plasmapheresis, right? And now coming to the surgical management. Common sense. So I told you most of the cases are associated with thymic hyperplasia. Now I can remove it surgically in refractory cases. So you have given the patient is on treatment and very frequently is coming to the clinic with the complaints of weakness. That's a refractory cases of thymic your myasthenia gravis. Yes, there will be involvement by your thymus gland, and now now you will hand over the case to the surgeon to remove the thymus gland and send back the patient to the medicine OPD, right? So surgical management will be thymectomy. You have to do thymectomy, right? In refractive cases, in refractory cases of myasthenia gravis, I'm going to do thymectomy and I'm going to treat. This is how. So this is what you need to know about myasthenia gravis. So any clarity you people require on this topic or any doubts, you can ask me if you have any doubts. Otherwise, I'll proceed with my next condition, which is your there's something which is left in myasthenia gravis. I'll go with that. Okay, so now listen to this. Okay, if you are clear, then I'm happy for that. So see here. Suppose now there is a myasthenia gravis client, and I'm giving the you as a nursing officer on a discharge, you have explained all the medicines and you have given all the medicines and you have sent the patient to the home, and now the patient is not taking properly the medicines, right? What it can happen is it can exacerbate the condition, right? So due to low intake of the medications, so the what happens, so low means there is no stimulation to the your acetylcholine receptors. Now what can happen, right? It can lead to respiratory failure, right? So right, and how to treat myasthenic crisis is by giving IV, IG or Plex. Suppose if the patient is taking medicines excessively, right? This is another case, right? Ativrishti anavrishti antar kada, that is what. So myasthenic crisis is low intake of medications and cholinergic crisis is excessive intake of medications. So whenever the patient is taking the medications excessively, now what happens, it will lead to excessive stimulation of neuromuscular junction, right? Leading again, this can lead to respiratory failure. So both your myasthenic crisis and cholinergic crisis will lead to respiratory failure, right? So here in myasthenic crisis, I'm going to give IVIG or Plex and I'm going to treat myasthenic crisis, whereas in case of cholinergic crisis, I am going to give a separate drug which is called as atropine, right? Which is a vagolytic drug. I'm going to give this atropine and I'm going to treat the case of cholinergic crisis, right? Okay. Your atropine is an anticholinergic agent, right? Okay. So now, so completed with our myasthenia gravis and starting with one more important condition. It's a very important condition that you need to focus on, multiple sclerosis, right? So now coming to multiple sclerosis, see, unlike your Guillain-Barré syndrome and myasthenia gravis, what is happening in myasthenia gravis and your Guillain-Barré syndrome? Antibodies are produced, but here myasthenia in multiple sclerosis, no antibodies are seen. No antibodies are seen, but it's a kind of autoimmune disorder, but no antibodies are seen. What is happening exactly in multiple sclerosis is, see, there are T cells, T type lymphocytes, which are getting produced in the periphery, and they will migrate to the brain and they will lead to the demyelination of the central nervous system. Okay, so multiple sclerosis, what is happening in multiple sclerosis? So it's a T cell disorder. It's a T cell disorder, right? And it is the most common demyelinating disease of central nervous system. Very, very important. please try to remember multiple sclerosis. It's a kind of autoimmune disorder where antibodies are not produced. No antibodies are produced in multiple sclerosis. Instead, there is something involvement by your T type lymphocytes, where these T cells or which are produced now they will migrate to the central nervous system, that is your brain and spinal cord. It will damage the myelin sheath of your central nervous system. And if anybody asks you what is the most common demyelinating disease of central nervous system, it is multiple sclerosis, right? So demyelinating disease of peripheral nervous system is Guillain-Barré syndrome. Demyelinating disease of central nervous system is your multiple sclerosis, right? Okay. So now, myelin sheath formation. So how, yesterday I told you, right? Myelin sheath, from where it is getting formed. In case of central nervous system, your oligodendrocytes. In case of peripheral nervous system, it is formed by Schwann cells, right? So in case of central nervous system, it is oligodendrocytes which are forming the myelin sheath. Now, again, as this oligodendrocytes, what is happening here? This cells will go on attack, leading to demyelination of your central nervous system. So most commonly seen in females. This is most commonly seen in females in between the age of 30 to 40 years of age, right? And the most common subtype of multiple sclerosis that you need to remember for your exam is the most common subtype that you need to remember is that there are different types of multiple sclerosis, among which, please remember this, that's enough for your NORCET exam, which is relapsing remitting multiple sclerosis. Relapsing remitting multiple sclerosis is the most common type of multiple sclerosis, where 85% of multiple sclerosis will be diagnosed with relapsing remitting type, right? And what is, Suman sir, what is this relapsing remitting type of multiple sclerosis? Just tell us in detail. So here the patient, what did I say? What is happening in multiple sclerosis? There is demyelination which is happening, right? The myelin sheath of your central nervous system is getting damaged. The demyelination is happening, right? So the patient will come to you with demyelination. Okay, so that means there will be severe symptoms due to demyelination. And just a minute. So the symptoms will be, see here. So there will be deterioration in the health. So due to demyelination, so the patient health will get deteriorated. And now again, even if you don't treat these cases, even the patient is not on steroids or whatever it may be, automatically there will be remyelination which happens and the condition gets improved. Okay, so there will be demyelination and remyelination, demyelination, remyelination, demyelination, remyelination. So this is what it happens. And have you observed this carefully which I have drawn here? So if you consider this line as normal state, the normal health state of the patient, he for with every episode of relapse and relapse, he is not coming back to the normal state. So there will be, in every relapse there will be little bit deterioration of the health. So see here, right, the step is moving down. So every time, if every time he's of his relapse, he's not going to come back to his previous state. Every time on his relapse, his health will be little, there will be a small deterioration. So right, in every relapse, and finally he will become bedridden. Okay, so finally patient will become bedridden. So this is called as relapsing remitting multiple sclerosis, right? And there is one more subtype of multiple sclerosis which is associated with poor prognosis, right? So which is called as PPMS, that is primary progressive multiple sclerosis. So here, once the patient is diagnosed with multiple sclerosis, there will be no improvement, there will be only deterioration in the health, and he will become bedridden. right? So this is called primary progressive multiple sclerosis, right? It's a very severe type of multiple sclerosis, right? The dangerous type, I can say. And even there is no treatment for primary progressive multiple sclerosis, right? Now let us see how the patients are going to come. The symptoms, the most common symptom of multiple sclerosis is fatigue, and it's very difficult to treat. Weakness, okay, and it's very difficult to treat. And if they ask you what is the most common neurological symptom, what is the most common neurological symptom is decreased sensation. The patient will complain you there is decrease in sensation or tingling sensations, that is paresthesias. Okay, and now since your central nervous system is involved, central nervous system, your cranial nerves, everything comes, right? Your central nervous system, your brain, and your spinal cord, here there are chances for your cranial nerves also the your optic nerve can get affected, so leading to optic neuritis. Optic neuritis, there will be visual disturbances in this multiple sclerosis patient. So all of a sudden he will come. Till yesterday I could able to see, and all of a sudden there is blindness, all of a sudden there is loss of visual acuity, all of a sudden he will complain to you. So it is due to optic neuritis, very 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 important. Okay, so there will be disturbances, visual disturbances in case of myasthenia gravis, sorry, multiple sclerosis. And coming to the motor symptoms, so what can be the motor symptoms? There will be stiffness, okay, spasticity, mainly the leg stiffness. Okay, the legs will become, the muscles in the legs will become very very stiff, as if the patient cannot walk, right? And okay, so muscle spasticity can be seen in case of motor symptoms. And if cerebellum is involved, cerebellum is also your central nervous system only, right? So if cerebellum is involved, see, any condition, if cerebellum is involved, obviously it is going to have, the patient is going to have gait abnormalities, the patient will have ataxia, cerebellar ataxia, and there will be tremors, there will be tremors, and there will be different type of speech you're going to see if cerebellum is involved, which is called as scanning speech. Okay, these are the symptoms if cerebellum is involved in multiple sclerosis. And there are few special signs that you need to remember, very 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 important for your NORCET exam, right? So number one, Lermite sign. Lermite sign, what is Lermite sign? Okay, so suppose what you are going to do here is you will ask the patient to bend his neck. So here you will ask the patient to bend his neck, and immediately he will wince with, he will tell you that he felt a shock like sensation all down the spine. Okay, immediately he will get a shock like sensation down, all down the spine. So that is called as Lermite sign, which is also called as barber chair sign. Okay, what is the barber is going to do in saloon? He will ask you to bend the neck. Okay, so that is what, so whenever you ask the patient to bend the neck, so they will have the shock like sensation, which is called as Lermite sign, very very important. And there is one more phenomena that you need to remember in multiple sclerosis, which is called as Uthoff phenomena. Uthoff phenomena. So here the client will come and tell you, sir, today morning, usually I will have cold showers. Today morning I had a hot shower, right? Immediately there is increase in my symptoms, aggravated. My symptoms became severe. So yes, there's something called heat intolerance in case of multiple sclerosis, right? So that means whenever the patient this multiple sclerosis, when they travel to the hot and humid climates, like when they travel to like even Delhi is it's very there will be very sunny here in summer days. So like Rajasthan, and when they move there, so where there's more heat and humidity, right? So right, so where there will be, these persons will be having heat intolerance. So when when they're getting exposed to the extreme temperatures like hot weathers, so the symptoms get increased and they become severe. So that is called as Uthoff phenomena. And there is something called Pulf-Rich phenomena that you need to remember. What is Pulf-Rich phenomena? So how many people of you watched 3D movies? I think every one of you would have watched at least once in your life the 3D movie, right? So here the patient will tell you, so whatever whomever is moving in front of his eyes, as if he will tell you that I could able to see them in a 3D view, right? So this is called pulp rich phenomena. So these are the three important special signs of multiple sclerosis that you need to remember. One is Lermite sign, which is also called as Barber chain sign. The another one is Uthoff phenomena, the heat intolerance, and the pulp rich phenomena, the 3D dimensional view which they are going to experience in case of multiple sclerosis, right? So these are the special signs seen in multiple sclerosis. And now how I'm going to diagnose the multiple sclerosis, the gold standard to diagnose multiple sclerosis will be always MRI scan. Okay, and I can also do a lumbar puncture and do CSF analysis. And what I am going to see in case of CSF analysis here in case of multiple sclerosis? And my dears, tell me, what is the finding that you're going to see in Guillain-Barré syndrome? In case of Guillain-Barré syndrome, in CSF analysis, I told you there is a special finding that you're going to see. What is that? Yes, there will be, yeah, here there will be increase in gamma globulins, and there is something called oligoclonal bands. Clonal bands that you're going to see, and there will be increase in IgG levels in case of CSF. That is confirmative diagnosis of your multiple sclerosis. But what did I say in Guillain-Barré syndrome? What is the finding of CSF? There will be high proteins. What did I say that? What is the finding called? Albuminocytological dissociation, which is seen in case of Guillain-Barré syndrome, right? So the gold standard investigation in multiple sclerosis will be MRI. Next is the CSF finding in multiple sclerosis will be oligoclonal bands. And there is a special criteria to diagnose multiple sclerosis. It's very, very important. No, you don't want the entire criteria to remember, because you don't want to diagnose. So just remember the name of the criteria. It's very important. The McDonald's criteria. McD, burger, you can remember. So McDonald's criteria is used to diagnose multiple sclerosis. And now, how I'm going to manage the case? Tell me. How I'm going to manage the multiple sclerosis? Tell me. For acute attacks, I'm going to give corticosteroids. Okay, IV steroids I'm going to give. And there's a very safe treatment that I can give in multiple sclerosis, which is called as interferon therapy. Interferon therapy, like interferon beta. Okay, interferon beta. I can give interferon beta, which is the safest drug to treat multiple sclerosis with no side effects in future. So I can place a patient on interferon beta, and I can there is one more which is called as glatiramir acetate. That I can start in case of multiple sclerosis. Although there are many drugs which are available nowadays to treat multiple sclerosis, this is what you need to remember for your exam. And since I told you there will be spasticity in multiple sclerosis, how I will be treating spasticity, right? I can give a drug called baclofen to treat spasticity. And nowadays there is a special I think you people are aware of this procedure or not, I don't know. Mainly in cities this is very commonly done. In dermatology we do Botox, right? Botox injections to freeze the muscles, right? the wrinkles, to freeze the wrinkles, we are giving Botox. Similarly, the same Botox can be given. Similarly, the same Botox also can be given. The same Botox, botulinum toxin injections can be given here also in case of multiple sclerosis to treat the spasticity of muscle, so that this botulinum toxin will paralyze that muscle and it will relax the muscle. So that is right. So now, for the fatigue, so I told you in multiple sclerosis, the patient will just come and sit in front of you and saying that fatigue. So now how we will work up? So the fatigue will be the most common complaint in multiple sclerosis. Here to treat fatigue, I can give a drug called amantadine, right? So this is how I'm going to treat a case of multiple sclerosis. Starting with Parkinson's disease, right? Have you seen the elderly people in your home, like who is at 80s, 90s, right?